Well, thanks so much for joining me today for the 7th episode of the 2nd season of the Healthy Skeptic MD podcast. I'm Dr. Michael Hochman. Today, we're going to continue our focus on key common health topics. And if you have an idea for a health topic that you want to learn more about, just let me know. You can post on my YouTube channel, on social media, or you can email me at healthyskepticmd@gmail.com. Now, today we're going to talk about breast cancer screening. Everything from does it work, to what are the harms, to does everyone need a 3D mammogram, and if so, what is a 3D mammogram? And also, how will breast cancer screening look 10 years from now? My guest today is Dr. Christoph Lee, a longtime friend of mine, former office partner of mine. We were both Robert Wood Johnson clinical scholars together a few years ago at UCLA. Christoph is now a professor at the University of Washington School of Medicine, where he's a breast radiologist and does research on this topic. As an aside, as a medical student, Christoph wrote one of the first studies highlighting the potential harms of radiation exposure from medical imaging. Very impressive to do as a medical student, and that study did have a lot of impact. So today we'll also have a chance to ask Christoph a little bit about that. If you find today's episode engaging, please do sign up, subscribe to the Healthy Skeptic MD on YouTube or wherever you listen to podcasts. Please pass it along to friends, family, and colleagues who might be interested, and consider leaving a review. So before we jump into our interview this week, let's start with two noteworthy health news items. So the first is a study of a new weight loss medication, semaglutide, which is also approved for the treatment of diabetes. This was a study published in the New England Journal this week, and over 15 months, it was associated with a 28-pound weight loss in overweight patients compared to those who received a placebo pill. These patients also had improved physical functioning, energy levels. There was some associated nausea and vomiting as a side effect, but these side effects were relatively mild. Now, I must say, this is a pretty impressive finding, a 28-pound weight loss, but this would not be the Healthy Skeptic podcast if we didn't ask some questions. So the first of these is, what's the long-term safety of semaglutide? We've known that many previous weight loss medications have been associated with longer-term cardiovascular and other severe side effects, so this is certainly something to track. And also, what's the impact of semaglutide on some obesity-related complications like heart disease, kidney disease, diabetes, and so forth? I must admit, these findings are impressive overall, and I think we are going to be hearing more about semaglutide in the months and years to come, but these are certainly some lingering questions that need to be answered before this medication can be used on a wide scale. On a less impressive note, the second news item this week is the most rigorous study we've gotten so far on the role of vitamin D supplementation for treating COVID-19 infections. This was a JAMA study. It looked at high-dose vitamin D supplementation in patients who were hospitalized with moderate or severe COVID-19. The study failed to demonstrate a benefit of high-dose vitamin D supplementation. Now, interestingly, this pattern has been seen over and over again with vitamin D, where preliminary studies seem to suggest a benefit of higher vitamin D levels for a variety of different conditions, from heart disease and cancer to even low energy levels. But then the rigorous studies come along and fail to confirm that benefit. And I think what this is telling us is that vitamin D, which we get from sunlight and being outdoors and being physically active, is a marker of health. But a supplement, a pill, doesn't actually cause us to have improved health outcomes. So unless you really have low deficient levels of vitamin D, there's not really a huge role and a significant role for vitamin D supplementation. I think this is something we should keep in mind, because we will very likely see more headlines about vitamin D being associated with improved health for some condition or other. So that's it for the news summary of the week. Let's jump into our interview with Dr. Christoph Lee. Well, welcome to the show, Dr. Christoph Lee.
Thanks for having me. It's a pleasure to be here.
So Christoph and I have some history together. We were both Robert Wood Johnson fellows together a few years ago, I think in 2010 at UCLA. And we both found out at the same time we were having daughters who ended up being born a couple weeks apart. And they've truly been lifelong friends, although Christoph and his family moved up to Seattle a few years ago. So I have to first ask you, Christoph, how's the weather up there in Seattle?
Well, today, actually, we got some sunshine, but it is a little rainy. We do miss the Southern California sunshine.
Yeah, so hopefully At some point, Christoph, we can convince them to move back south down here. Okay, so Christoph, you are a radiologist specializing in breast imaging at the University of Washington. You do clinical practice and research. Could you just begin by telling us a little bit about your practice and your research?
Sure thing. So, like you mentioned, I went through my radiology training in diagnostic radiology. And after that, I did 2 fellowships at UCLA. One, the Robert Johnson Clinical Scholars Program with my esteemed colleague, Dr. Hockman, and a breast imaging fellowship where I spent a time at UCLA Iris Cancer Center focusing on imaging around breast cancer. So currently I practice at the Seattle Cancer Care Alliance, which is the University of Washington's cancer center. We actually serve a large geographic area, since the University of Washington serves not only the state of Washington, but also Alaska, Idaho, Wyoming, Montana. My practice is strictly in breast cancer imaging, everything from screening mammography, which we'll talk about today, to more advanced imaging modalities like MRIs and procedures like biopsies and localizations prior to surgery. In terms of research, I do spend a considerable amount of my time in my research enterprise. I have a center called the Northwest Screening and Cancer Outcomes Research Enterprise, or Northwest SCORE for short. And what we're trying to do with this unique collaboration is to build a large breast cancer screening registry where we're collecting data at the exam level. And this large data could be used in de-identified form to inform practice as well as policymakers like the U.S. Preventive Services Task Force, American Cancer Society, that put out screening guidelines.
Yeah, so Christoph's a really humble guy. He's very well funded by the NIH and is doing some really important work. And I believe now you're a full professor, if I have that right, at the University of Washington, Christoph?
That's right.
Very well-respected researcher. Now, before we get into the topic of breast cancer screening, which is going to be our focus today, I actually first heard your name when we were both medical students. We were at different medical schools because you had done a study that got truly international attention. You did the simple thing of surveying people to ask if they understood the radiation exposure that they were getting from common radiology studies. Could you just tell us a little bit about that work?
Sure. I was a first-year med student at Yale in 2001, and I had just spent a few years after college. By the way, Mike and I went to the same college, but we actually didn't know each other at that time. But I spent a few years both in healthcare consulting as well as healthcare advocacy work. And I actually got matched up for my thesis, and my advisor happened to be a radiologist named Howie Foreman, who also was a Robert Johnson Clinical Scholar back in the day. And we were like-minded in terms of our health policy interests. And he brought up this topic of radiation exposure. We did a simple survey in the Yale Emergency Department of residents, of attending radiologists and emergency medicine physicians, as well as the patients undergoing CT scans, about their awareness level of how much radiation exposure they were getting from their CT scans. It was really surprising to know that patients, physicians, and radiologists alike could not determine the level of radiation exposure from a simple CT scan. So this was published in our premier journal in radiology and did get a lot of press coverage. And we like to think that this kind of led to larger campaigns for decreasing radiation dose, like Imaging Wisely, part of the Choosing Wisely initiative of not overdoing tests that may not have benefit in order to prevent harms from radiation exposure.
Yeah, Christoph, along these lines, one question I always get from my patients, I hope I'm not putting you on the spot here, but I always get asked the question, how much radiation do I get from, for example, a chest CT or a mammogram? Are there a couple kind of high-level ways that you could communicate that to a patient?
I think the easiest approach is to compare to something that everyone is familiar with. So we tend to use the example of flying across the country from LA to New York. a transcontinental flight. And that, because you're elevated at a higher level, closer to cosmic rays, you tend to get a radiation dose just from that 5-hour plane flight as you would from a 2-view chest x-ray. So if you think about it that way, it kind of puts into perspective how much radiation exposure you get. Even though, say, a CT abdomen and pelvis is 200, 250 chest x-rays, it sounds like a lot, but in actuality, it is quite low when you think about the overall exposure you get from the environment. So someone living in Denver, for instance, will have 3.5 millisieverts of radiation exposure a year. A CT scan is usually lower than that, of about 1 to 2 millisieverts. So the exposure you get from medical imaging usually is not something to be concerned about if you need the exam, especially if you have an emergency and that CT exam is going to help you determine the best management.
One other question, there may not be a direct answer to this, but sometimes patients will say, what are the chances that if I get this chest CT that it will lead to a cancer? Is there any data that you know of off the top of your head about that?
The risks are quite low, right? And when we look at, say, chest CTs or mammograms, and we take mammogram as an example, the exposure, again, is over time, right? So you're getting mammograms every year or 2 years. That could add up over a lifetime. But even if we look at the entire lifetime exposure just from screening mammograms, we're talking about very, very small numbers of cancers that we're talking about maybe 1 in 10,000 that may end up having a radiation-induced breast cancer.
Yeah, I think that really does help to put it in perspective. And as you pointed out, actually the doctors have been doing a better job of lowering the radiation dose that people get from common exposures through the Imaging Wisely campaign that you referred to a moment ago.
That's right. And since 2001, since that study out of Yale, a lot has happened over 2 decades where low dose protocols are really the standard of care now. So when you go, say, get a chest CT to screen for lung cancer, those are low dose CT scans that are really just a fraction of the radiation dose that we had a decade or 2 ago.
So one area where there really has been an improvement in this safety issue. Okay, so Christoph, today we're going to focus on screening mammography, which is obviously important to a lot of people. And as I was prepping for today's session, I did a little research, and I found out that screening mammograms date back to the 1950s. I should say mammograms are, of course, just an X-ray of the breast tissue. Tell us a little bit about the history of mammograms and breast cancer screening in the U.S.
It's fascinating that we call these tests mammograms. They started off as what were called xenograms, where they were sort of inverse X-rays of the breasts. And that name turned into mammograms, and that's really kind of stuck with this test. But the big take-home here is that breast cancer screening tests, what we call mammograms, dating back to 50s, 60s, 70s, those are not the same tests that we have today. But recall that we went from screen film to digital mammography in the 2000s. In the 2010s, we've switched to digital breast tomosynthesis, which are 3D mammograms. So rather than the 2D images we used to look at, we've now converted to looking at 3D mammograms, where you could think of it as a poor man's CT. We're taking several X-ray cuts through the breast and actually scrolling through the images. So we could scroll through basically every square inch of the breast, and we didn't have this technology a decade ago. Where we were stuck with this 2D X-ray and we're trying to figure out overlapping tissue. That's no longer the case.
And actually, that's one thing we're going to talk about is how some of the technology has evolved, and that's one of the areas that where you do research. So we're definitely going to come back to that. Generally speaking, we've talked in this podcast, the Healthy Skeptic MD, about some of the pitfalls of medical care. And it might seem straightforward that breast cancer screening is always going to be a good thing, but there are potential downsides, false alarms, and so forth. What pitfalls can you run into with screening mammograms?
Certainly. So we know that in practice, about 1 in 10 women, 1 in 11 women will be called back for additional views. The screening test or screening digital breast tomosynthesis in current day will pick up on things and be quite sensitive. Sometimes those are cancers and sometimes those aren't. So one of the biggest risks of screening are these false positives, where a woman has to be called back for additional diagnostic imaging, but eventually are found to have either benign disease or no real finding at all. But for a fraction of women, we'll have to move on to biopsy to rule out cancer. And so there is this spectrum of diagnostic workup that are additional costs, additional time, and could be slightly invasive if a biopsy is necessary.
And one other potential pitfall is this concept of overdiagnosis, getting diagnosed with a breast cancer that if you hadn't done the screening might not have ever become apparent in that woman's lifetime. Any sense of how commonly that happens?
Yeah. And it really depends on who you ask, right? Overdiagnosis is something that everyone agrees happens, but to what extent is where the controversy lies. There have been estimates, as high as 30, 35%, and as low as 0%. The truth probably lies somewhere in the middle. A lot of really smart people have thought about ways to take our birth cohorts and simulate different types of scenarios. And what we call the Cancer Imaging Surveillance Network, or CISNet, they've developed these really sophisticated simulation models of breast cancer screening. And they are the ones that actually are informing a lot of our guidelines right now. The American Cancer Society, the U.S. Preventive Services Task Force rely on simulation modeling because we don't have recent trial data. Those simulation modeling studies tend to put overdiagnosis at about 10 to 15%. And to me, that seems pretty believable. So
somewhere in the middle, as you said.
Exactly.
Yeah, and I think it's really important to understand the potential pitfalls of breast cancer because, as I think we're going to talk about, a lot of the new technologies for breast cancer screening are not necessarily about catching more disease. Maybe there's a little bit of that, but it's also just as much about avoiding the unnecessary workups and avoiding catching those overdiagnosed cancers. Is there a way that we can be more specific and targeted with what we identify? Another point that frequently comes up, Christoph, breast cancer treatment has improved a lot over the last couple decades. And the whole idea behind screening is that you catch it early so you can still intervene. But as treatments get better and better, it's been argued that the importance of catching it early, while still important, isn't as important as it previously was. Can you comment on that?
It's one of these things where I think it's both. You have to realize that, like we've been talking about today, screening tests have changed over time and treatments have changed over time. So trying to say that, okay, mammograms have stayed static, but treatments have improved and therefore the mortality reduction we're seeing is from treatment is incorrect. And the fact is that the screening has gotten better, the treatments have gotten better, and both are likely contributing.
Okay, so we want to know the net effects of breast cancer screening, both the pros and the cons. And the best way to do that is the randomized trial in which half the women are assigned to a mammogram and the other half don't get it. There have been 9 such randomized trials that I'm aware of in breast cancer. They were summarized in a well-known Cochrane review of the literature. Could you distill what that study showed for the audience?
Overall, that these systematic reviews, when you look at the randomized controlled trials, overall are showing that there is a breast cancer specific mortality reduction in the order of about 15 to 17% with screening mammography. There is a lot of debate whether women 40 to 49 in that younger age group have any benefit in terms of reduced mortality relative to the harms of screening that we've spoken about. But there is actually no controversy that when taken together, these randomized controlled trials have shown a breast cancer specific reduction in mortality of about 15 to 17%. There's also no controversy that there's a mortality reduction in women 40 to 49 as well, when you look at the studies in totality. It's just the controversy is around weighing the harms versus those benefits and understanding when benefits outweigh risks. I understand that the Cochrane review and other systematic reviews with these RCTs show no overall mortality benefit, right? So we're talking about all-cause mortality. So a woman may not die from their breast cancer, but they may die of heart disease, and they didn't gain any years of life from their screening. What's being missed in this picture is that we're not talking about the quality of those years. Personally, having family members that have gone through late-stage disease and breast cancer, gone through the systemic treatments, their quality of life is diminished because they didn't get that earlier detection. And those are quality of life years that we have to look at, and not all-cause mortality.
Well, I think really good points there. In this podcast, I try to have a skeptical view of the medical system, but I think to focus only on does a treatment improve life expectancy, we're missing a big piece, and we often fail to consider the benefits of medical care in terms of quality of life and avoidance of unnecessary suffering if we can catch things early. So I think that's a really good point that we often don't take into consideration. Well, I want to shift a little bit and talk about some of the newer technologies, because I know you're really on the forefront of this. You talked about tomosynthesis. Just a couple more questions on that. One is, how much additional radiation occurs with tomosynthesis? And secondly, is this technology widespread? Is every woman getting tomosynthesis? And if not, should they be?
That's a great question. I want to make one more point just about the quality of life before we move on to new technologies. One of the more recent trials was the digital mammography imaging screening trial that showed equivalent accuracy of digital mammography to screen film mammography. From that study, where we looked at quality of life issues for women, false positives and being called back from screening were transient influences on quality of life. So very temporary anxiety that disappeared after 5 weeks. So when we talk about false positives as the biggest harm from screening mammography, realize that the data from these large clinical trials show that these false positives are actually not a big deal from the women's perspective, that these levels of anxiety that are provoked go away within 5 weeks, and their quality of life comes back to their steady state. So even though
I would actually just second that from a personal perspective. You mentioned, Christoph, that we went to college together. We actually both went to Princeton, and I remember the week before I was supposed to go to college, my mom had a concerning mammogram, and it caused a lot of anxiety, and I certainly remember it because it was right before I was about to go off for college. Fortunately, everything turned out just fine. So it was a real concern at the time, but in retrospect, it's a distant memory, almost as, sort of a funny recollection from right before I went to college. Thank goodness that's the way it turned out. So I certainly second your point there that these transient areas of concern maybe shouldn't dissuade us if there's real other benefits. I do think that the overdiagnosis issue is an important one because that's something that would lead to treatment that otherwise wouldn't be necessary. But I'm sorry, I think you were continuing on something.
No, certainly. I think those are great points. In terms of new technologies, you asked about new technologies in the forefront of breast cancer screening. We talked about digital breast tomosynthesis and 3D mammography. It really is becoming the modality of choice. Based on FDA facility files, we know that over 67%, 2/3 of mammography screening facilities in the US currently have a DBT unit. So they're able to offer 3D mammography. But only 45% of all mammography units are actually 3D capable right now. What's exciting about 3D mammography and what we're seeing is that it's decreasing the recall rate, meaning that it's decreasing the proportion of women that are called back with an abnormal screening test. At the same time, we're seeing an increase in cancer detection. In terms of radiation dose, early on, when tomosynthesis was FDA approved in 2011, people were not sure how to switch completely from 2D to 3D, right? Remember, it's slightly different. Radiologists looking at essentially a 2D X-ray versus scrolling through 3D images of the breast. So for a while, people were doing both a 2D and 3D mammogram side by side. that essentially doubled the radiation dose. And that's not what we wanted to do. Once the technology actually caught up, though, we realized that we could synthetically create a 2D mammogram from our 3D acquisition. So we've gotten away from a double exposure to radiation dose that's comparable to a 2D mammogram, which is really good news.
And Christoph, do all the women who get screened for breast cancer at University of Washington, are they all now getting tomosynthesis?
As I mentioned, not all facilities have 3D mammography, and not all states will reimburse for 3D mammography. Because it's a newer technology, it really depends on third-party payers. The state of Washington is willing to cover the additional costs in terms of the technology, in terms of interpretation time for radiologists, but a lot of third-party payers are not willing to do that. So for some women, there might be out-of-pocket costs still in certain areas, and that could limit their access to 3D mammography.
Yeah, many of my listeners are actually the lay public. Would you recommend that women try to find a facility that offers tomosynthesis?
It's a very difficult question because overall, I'd say yes. I think 3D mammography will increase cancer detection and decrease recall. But we are seeing that 3D mammography works better in certain subpopulations of women based on their age, their breast density. But for women at the really high, extremely dense population, the data is actually showing that they don't benefit from 3D mammography because their breasts are so dense that the extra scrolling through doesn't actually help us all that much. So those women, that 10% of the population, I think it's still appropriate to just get a 2D mammogram. And these are incremental benefits. So if all they have is 2D in their location, it's still very effective and very accurate.
And the dense breasts topic actually just triggers another question that comes up all the time. I think in many states, I believe in California, women who do have dense breasts get a letter in the mail saying that the mammogram may not be as accurate in their case. It sounds like tomosynthesis or 3D mammography is not the answer there. What should a woman do if they get that letter in the mail?
This is a big credit in terms of the patient advocacy community and folks like Nancy Capello and rudense.org, densebreastinfo.org. They brought this issue to the forefront around 2010, 2011. And it's actually been the patient advocates that have moved this issue forward to the forefront and passed state legislation requiring radiology facilities to directly inform women of their breast density. Because breast density is a modest risk factor for developing cancer and is a risk factor for having cancer missed on a mammogram. But what it has done is it's made the healthcare community and the radiology community have to react to that and react to that legislation. And what we're seeing, at least from the scientific evidence, is that supplemental screening ultrasound, which is probably the more ubiquitous supplemental screening test to 2D and 3D mammograms, are not beneficial relative to their harms, right? So when we talk about the ability of mammography to detect cancer early and their sensitivity, that's about 87% in the population. That's pretty good, right, for a screening test. Screening ultrasound only has a sensitivity of 55%, which is really low for a screening test. And what that does is balloons the number of false positives that you're going to see, because as you screen more, you're going to see more. So for women with dense breasts getting supplemental screening ultrasound, it's highly likely those screening ultrasounds not only won't find additional cancers, but will find false positives and lead to unnecessary benign biopsies.
So to summarize what you're saying, it seems like it's a good thing that women know if they have dense breasts that the mammogram isn't maybe as sensitive and they may be at somewhat higher risk for developing breast cancer, but we actually don't know exactly the right way to handle that situation. We don't know. It doesn't seem certainly that ultrasounds are the right solution for supplemental screening, and we certainly can't say that an MRI or any other supplemental technology is the right thing to do. Is that a fair characterization?
It is for women with dense breasts and no other risk factors, right? So, breast density is a pretty modest risk factor, and there are stronger risk factors like age and family history. If you take all those risk factors into consideration, then you're onto something. Then if you are at high risk based on all the risk factors together, breast density only being one of those risk factors, then there is evidence that you could benefit from, say, supplemental MRI. And we know that in certain populations, women with genetic mutations, supplemental MRI, in addition to mammography, is cost effective.
Well, let's make a quick note here that we had Dr. Vinay Prasad talk about genetic testing a couple episodes ago, and the one genetic test that he was comfortable recommending on a broader scale was the BRCA test to identify women at high risk for breast cancer. He wasn't saying every woman needs that, but women who have family histories do. And the reason is exactly what Christoph said. Those women would very well likely benefit from supplemental screening with an MRI. So one of those situations where supplemental screening does make sense. Well, Christoph, I want to talk a little bit about other technologies. So I know you have been doing a lot of work, your team, on artificial intelligence and using automated tools to help radiologists better interpret mammograms because, of course, the human eye is not perfect. Tell us a little bit about where the technology is for this. And I assume it doesn't apply just to breast radiology, but to really many types of radiology, if that's correct.
That's correct. I think there's really an explosion with artificial intelligence and medical imaging now. We have faster computers, a large amount of storage capabilities, and we're able to run these deep learning algorithms on hundreds, thousands, if not millions of exams. And being a radiologist, these are fascinating tools on the horizon. AI has the potential to detect imaging findings and abnormal imaging findings with greater accuracy and speed than human interpreters. And it could very well put me out of business. But what is exciting to see is that mammography and screening mammography has kind of become the poster child. We're the test case for AI and medical imaging because we have so many millions of exams that are all standardized in how we actually acquire the images. And we're looking for basically a binary thing, right? Cancer or no cancer. So computers love binary algorithms. Is there cancer or not? So we're able to train these supercomputers to search for cancers on mammograms. Recently, we published our results from what's called the Dream Digital Mammography Challenge, which is the largest crowdsourced effort in AI and medical imaging thus far. What we actually did, we got funding from the Laura and John Arnold Foundation and put $1 million prize up for global AI teams to challenge them to beat the radiologist. We had data from over 86,000 women. We had 1,100 participants throughout the globe trying to beat the radiologists. So over a year and a half, even the best challengers, unfortunately, couldn't beat the radiologists. But working together, they built a model that, combined with human interpretation, far exceeded the accuracy of human interpretation alone. We're on a direct path to actually putting those into clinical use. There are several AI algorithms that have received FDA approval for 2D and 3D mammography, and several more in the pipeline. We've been down this road before, though, in breast cancer screening with computer-aided detection, and we know, traditional computer-aided detection failed, partly because they weren't well tested and evaluated in clinical populations. So we're cautiously optimistic. We are planning a number of external evaluations of these promising technologies before we recommend widespread adoption.
Yeah, well, I think that's a general theme I've observed with the use of artificial intelligence in medicine in general. It's not yet at a stage where it's replacing doctors, but it can help us doctors make better decisions and maybe miss some things that we otherwise might. So you put it together and you get an even better output than you would with either alone. And I'll say, I don't see that you being replaced, certainly, Christoph, any time is soon. Hopefully, a technology like this will allow you to work at an even higher level, or radiologists in general to work at an even higher level. The other new technology I can't help but ask you about is the breast cancer blood test. Is that on the horizon?
There are products in the works, and I know that there are several groups and startups working in this space. What's interesting to note is just the heterogeneity of breast cancer, and trying to find one blood biomarker to help diagnose all types of breast cancer is going to be very challenging. I think that less heterogeneous disease entities that clearly could have one or two blood biomarkers that could detect disease are in better positions for having a blood test to detect cancer. What's, again, shocking about breast imaging and mammography, and the fact that we keep iterating upon it, is that we can't think of a better solution yet. And I hope that one day in my lifetime we could replace mammograms with a more accurate and more precise test for breast cancer specifically. But the jury's still out in terms of what that data is going to show for these newer blood tests.
And again, I would just recommend the Vinay Prasad podcast a couple of weeks ago. He talked in general about cancer blood tests and also shared your skepticism, I would say, and also concern that if we start getting all these concerning blood test values, what do we do with that information? Is it going to lead us down a path that could take us astray? So we really, as always, need to make sure that these new technologies actually lead to better outcomes for patients and don't just change the numbers in a certain way. Okay, the other idea, Christoph, for maximizing the value of breast cancer is to target it at the women most likely to benefit, a sort of a risk-based strategy. What's your latest thinking about risk-based breast cancer screening?
I think it's such a great topic. I work a lot with the Breast Cancer Surveillance Consortium that's really taking the lead on risk-based screening. If you look at any of our guidelines, they're age-based. They're age-based proposals. Women 40 to 49 should have shared decision-making. Women 50 to 74 should have biennial screening at the least. These are not really helpful for individual women to make their decision based on their own characteristics. What we want to do is build tools to tell a specific woman, based on your characteristics and risk factors, this is the tailored, personalized, risk-based screening approach you should take. You should add on or not add on MRI. You should get a 3D instead of a 2D mammogram every other year. You should stop screening at a certain age. You should start screening at a certain age. We need to be more specific based on individual characteristics in combination. So the tools that are being developed are taking into consideration not only your age, your breast density, and family risk factors, but I think the more really provocative idea is to take all of the necessary, all the available information there that could help you make a decision. That includes prior mammograms. So we're actually using AI to look back at the imaging features that we can't identify with our human eye, but are specific to individual women. And those imaging characteristics we're seeing are just as powerful as determining future cancer development risk as age and family history. If you combine all of that together, we're talking about a very personalized approach where we could tell a woman their exact risk for developing cancer then in the next 2 years, in the next 5 years, not just their lifetime risk, which is a very crude estimate that we rely upon right now to make medical decisions. So I think we could get to a point of very personalized risk-based screening where we're basically minimizing all the harms and maximizing all the benefits for individual women.
Yeah, that would certainly be great to see. And the only thing I would add to that from my primary care perspective, Christoph, is different people have different goals and values. And so certain people may value life living as long as possible, and other people quality of life. And also certain people may have shortened life because they have another cardiac condition. And all those factors should also be considered in optimizing who should get.
Most certainly.
Well, Christoph, I have two final questions for you. I try to stay out of politics in general with this podcast, but breast cancer screening has truly been mired in politics. I remember when guidelines came out about 10 years ago recommending screening be every 2 years instead of every one, and how politicians got involved and the backlash there. Why is it that breast cancer screening triggers such political emotions?
It's an emotional issue. I don't think there's any individual that we know of that hasn't been personally touched or knows someone in their family or extended friend network that hasn't dealt with breast cancer in some way or another. It is a gender-specific organ that really leads to a lot of emotions, right? About families, about our overall well-being in general. And I think it's touched everyone personally. For that reason, I think emotions have really kind of been conflated and confused with the science and the evidence and the passion. It's unfortunate that it's been politicized in a way. But if we go back to the evidence, we know that some women are going to benefit. We know that some women are going to be harmed. It's not an all or nothing proposition. We don't have to throw out screening for everyone because we think that overall the risks outweigh the benefits somewhat overall, because we know that the benefits far outweigh the risks for a good proportion of women. So again, I think, we don't want this to become mass in the era of COVID and politicizing it, but we want to acknowledge that there are real benefits to mammography screening and there are real harms. And it's a matter of mitigating those harms and maximizing those benefits.
Yeah, and if there is a silver lining to it, I think it shows that people really care about women's health and public health issues. So, it's not always a bad thing when advocacy groups get out there and draw attention to an issue, and there's certainly some good things to come about it. I think the key that you and I would agree on is that we want it to be science and rational decision making that's driving policy at the end of the day. Well, one final question to get you to respond to, Christoph. The previous season of this podcast, I had Dr. Gil Welch, who's a well-known skeptic of certainly many types of preventive care. He's really done a lot of research highlighting the harms of screening tests, including breast cancer screening. And he made the statement that he's not convinced, based on the data, that for most women, that mammograms make sense. I'd love to get a counter perspective on that from you.
Well, I respect Dr. Welch, and I do agree with him that any type of healthcare is a choice, including screening, right? And but I disagree that the evidence isn't there of benefits, and that it could be worthwhile for a good proportion of women. The randomized controlled trials, there's no disagreement that mortality decreases with screening mammography use. And there's also no disagreement that there is an element of overdiagnosis. But what I want to point out again is that we can't focus just on mortality and mortality-specific benefit. We need to look at how earlier detection of cancers like breast cancer that, if not detected, could go on to local advanced disease, to go on to metastatic disease, and to lead to real morbidity that a woman's going to suffer through for the rest of her life. It's these types of outcomes that are more patient-centered, that women actually care about, that we have to look at more when we look at breast cancer screening outcomes. Because I agree, the evidence, when you look at it, overall mortality benefit may not be apparent, but overall morbidity benefit also hasn't been examined. And I think that overall morbidity benefit would outweigh a lot of the overall mortality benefit when we're talking about populations of women.
I think that's very well said. And, I like you, I'm a big fan of shared decision making. I think people should go in with their eyes open to any medical decision. And in this one, it's a complicated one. But I think the way you describe it, women should have the opportunity if they feel that it could benefit to choose one way or the other, as long as it's an informed decision. And, I think it's really exciting, some of the technologies that you're involved in that could even further shift the equation in the favorable direction. Well, thank you so much for joining me today, Dr. Christoph Lee from the University of Washington, one of the best radiologists I know, and a really thoughtful person on these topics. If you found today's topic interesting, engaging, please pass this along to others who might be interested. Subscribe to the Healthy Skeptic MD wherever you listen to podcasts or on YouTube. Leave a review if you have a chance, and we'll pick it up again next week. Thanks for joining me.